The purpose of this research project was to evaluate the implementation of modernizing the Homes for Special Care program into the Community Homes for Opportunity program. Phase 1 occurred in a specific catchment area overseen by St. Joseph's Healthcare London, Parkwood Institute Mental Health. This evaluation examined the nature and experiences of tenants and Community Homes for Opportunity, or CHO, home staff in response to the modernization, as well as address the current policies and practices that either facilitated or interfered with the intended changes, and provide recommendations to improve the program. The research looks at the outcomes of the CHO clients as well as a review of the process to modernize the Homes for Special Care program in southwestern Ontario. This study evaluated the initial implementation of the plan to modernize the Homes for Special Care, or HSC, program. Process and outcome evaluations of the CHO program were conducted in 28 homes. Outcome evaluation assessed the effectiveness of the CHO program by measuring potential changes in the tenant's community integration, housing stability, health status, quality of life, social inclusion, and mental health at 3 measurement points: baseline or pre-implementation, transition, and the final implementation. Process evaluation aimed to identify facilitators, benefits, barriers, and challenges throughout the CHO program's implementation. To evaluate how the program outcomes or impacts were achieved, the researchers conducted focus groups with stakeholders including CHO tenants, homeowners, home staff, staff from the Ministry of Health, and staff from community agencies. A random sample of 115 tenants were recruited from 28 homes involved in the implementation of the CHO model. Tenants were invited to participate in semi-structured interviews containing both quantitative and qualitative measures. Measures include demographics such as age, sex, and psychiatric history, community integration, quality of life, health and social service utilization, and housing stability. Interviews were conducted at 3 time points, 4 months apart. Time point 1, or baseline, was called pre-implementation. Time point 2 was called the transition, and time point 3 was the final implementation. Focus groups were conducted with stakeholders. These included CHO tenants, homeowners, home employees, staff from community agencies, and staff from the Ministry of Health to identify issues, solutions, and recommendations for improvement. Focus groups with CHO tenants and staff occurred at 2 time points. The Ministry of Health and community agency staff focus groups were added in the second and third rounds of focus groups, that is, time 2 and time 3. An evaluation through the Institute of Clinical Evaluative Sciences, or ICES, will compare the healthcare utilization data for tenants from the first 28 homes pre- and post-implementation, and then compare this data to tenants in the Homes for Special Care program elsewhere in the province. A matched cohort has also been generated from ICES data to act as a comparison group. For each client recruited to the evaluation project, a match control has been drawn from the ICES database using a propensity score matching technique. The control group of matched controls has been created using data accessed through the Administrative Healthcare Database housed at ICES. Clients and controls have been compared on the healthcare service utilization. Outcomes of interest include hospital stay, hospital readmissions, physician visits, and emergency department visits. This graphic here summarizes the key findings that were identified in a comparative analysis between time 1, which occurred in spring of 2018, and time 3, which occurred in winter of 2019. These findings included improving the tenant's environment in some areas such as the staff's response to residents' needs, communication in the home, recording of tenants' information, and the autonomy of residents. Residents' quality of life improved from time 1 to time 3. Specifically, participants' general life satisfaction with their living situation, as well as satisfaction with their daily activities and with their financial situation. Improvements were also found in the participants' financial situation in both the participants' subjective report of satisfaction with the finances, as well as objective measures of income and the ability to provide basic needs. Reduction in social contacts was actually found between time 1 and time 3. Social contact was determined by the frequency of contact with friends, which might be less due to the new changes and activities that the tenants were involved in. Overall, community integration that includes participation in activities in home and participation in social activities remained relatively stable across time. Although scores were slightly higher at time 3 compared to time 1, which indicates that there was some improvement post-program implementation. There was also increases in the frequency of home visits from health and social service providers between time 1 and time 3. This could be attributed to an increase in the CHO workers' visits since the implementation of the program. Findings from the focus groups also identified some themes. This included that the implementation process was satisfactory to all the stakeholders despite the experience of some barriers and challenges. Successful working relationships among all stakeholders were observed. Increased financial support and promoting independence. Increased community integration and social inclusion for the tenants through greater access to community agencies. Tenants gained control and dignity. Perceived challenges due to the cultural shift from the homes from special care culture to the community homes for opportunity culture. Lack of information, lack of communication among all parties, and unclear guidelines and role descriptions for homeowners, staff, and community staff were also reported. Conflict arose from the different perspectives between a nonprofit agency supervising and a for-profit agency providing the housing support. There was also a need for a common organizational practice, as it referred to wellness plans, reporting system, medication protocol, food quality, and quantity. Descriptive statistics were conducted on demographic variables for participants who completed a baseline interview. The sample was between the ages of 23 and 79 years old, and the average age was 54 years old, and 42% were female. 74% of participants were single, 19% were separated or divorced, 3% were married or in a common law relationship, and 4% were widowed. The majority of participants, 48.3%, had completed high school. The majority of participants, 67%, were receiving income from the Ontario Disability Support Program, ODSP, and 41% reported ODSP as their only source of income. 95% of the sample had at least one psychiatric diagnosis, and 35% had more than one diagnosis. The most common diagnoses found among participants with a single psychiatric diagnosis was schizophrenia, 38%, mood disorders, 5%, anxiety disorders, 3%, and substance-related disorders, 1%. 8% of the sample had an unknown psychiatric diagnosis. Psychiatric diagnosis is present, but the type is unknown. And 4% had a psychiatric diagnosis that fell into another category, for example, a psychosomatic disorder or neurolepsy. 58% of the sample also had at least one physical illness, and 27% had multiple physical illnesses. The two most common physical illnesses identified by participants were diabetes, 15%, and high blood pressure, 4%. 24 participants had a psychiatric admission in the last year. Out of the 24 participants with a psychiatric admission, the average number of psychiatric admissions in the last year was 1.83. 109 participants stated that they had had a psychiatric hospitalization in their lifetime, and out of that 109, the average number of psychiatric hospitalizations over the course of the lifetime was 16. When asked, do you currently have any substance or addiction issues, 68.1% answered yes. The Therapeutic Environment Guideline, or TEG, was used to assess the general environment within the residences. Research assistants completed the TEG based on direct observations of the home and conversations with staff, tenants, and homeowners. A TEG was completed for only 27 residences during each of the interview rounds. One of the residences had a flood, and all the tenants had to be transferred to another CHO residence in the same region. The TEG consisted of 13 items that evaluated staff factors, such as staff qualifications, tenant factors, such as the autonomy of tenants, organizational factors, such as admission criteria, and safety factors, such as the prevention of aggression, as it pertains to the social and physical environment of the home. All items were given a rating from A, which corresponded to excellent, to E, which corresponded to dissatisfactory, based on guidelines outlined in the tag for each item. Responses on each tag item are coded into a numerical score as it follows. A equaled 1, B equaled 2, C equaled 3, D equaled 4, and E equaled 5. Lower scores indicate better ratings on the tag items. A paired sample sign test was conducted to assess whether scores on the tag for residences differed between the first and the final interview. There was a significant improvement for the average score on 4 of the items. These include staff responses to tenant needs, communication in the home, recording of tenant information, and the autonomy of tenants. There was no significant differences were found between time 1 and the final interview for all other items on the tag. The quality of life of the tenants was measured using Lehman's Quality of Life Interview brief version. This instrument measures subjective and objective quality of life in 9 domains. Subjective domains include general life satisfaction, health, safety, daily activity, family relationships, social relationships, employment, finances, and living situation. All subjective items are scored on a 7-point Likert scale. Scores range from 1, which corresponds to terrible, all the way to 7, which corresponds to delighted. Higher scores indicate better rating on the scale. Sample questions that were asked in each of the domains were, how do you feel about your life in general? Answer using the terrible to delighted scale. How do you feel about the living arrangements where you live, the privacy you have there? How do you feel about the way that you spend your spare time, the chance that you have to enjoy beautiful and pleasant things, the amount of fun you have? How do you feel about the amount of money you get, how comfortable you are financially, and how do you feel about the amount of money you have available for fun? A significant improvement was found on the general life satisfaction domain between time 1 and time 3. This indicated an increase in the participants' general life satisfaction from baseline to 3 months and after the proposed implementation. Significant improvements were also found for the following subjective quality of life domains between time 1 and time 3: satisfaction with living situation, satisfaction with daily activities, and satisfaction with financial situation. Improvement in these domains indicate that participants were more satisfied with their living conditions, activities, and finances after the implementation of the program. Objective domains include items regarding access to resources, such as the amount of monthly income, and the frequency of items, such as frequency of contact with family members, frequency of contact with other people who are not family. Samples of questions that were asked in each domains, for example, for family contact, in the past year, how often did you talk to a member of your family on the phone? In the past year, how often did you meet up with a member of your family? In terms of social contacts that are not family, questions asked were, how often do you do the following? Visit someone who doesn't live with you, telephone someone who doesn't live with you, do something with another person that you planned ahead of time, spend time with someone that you consider more than a friend, like a spouse or a boyfriend or a girlfriend. The rating scales were used were from 5 to 0. 5 corresponded to at least once a day, 4 at least once a week, 3 at least once a month, 2 less than once a month, and 1 not at all. 0 was also an option for participants who had no family. We also asked the participants questions regarding their financial adequacy. For example, we asked, during the past year, did you generally have enough money each month to cover the following: food, clothing, housing, traveling around the city for things like shopping or medical appointments or visiting friends and relatives, and social activities like movies or eating in a restaurant. There were significant increases in objective quality of life domains for financial adequacy and the amount of money available each month between time 1 and time 3. Financial adequacy scores were determined by whether participants reported having enough money each month to cover food, clothing, housing, traveling around the city, and social activities. There were improvements in the participants' financial situation in both objective reports of satisfaction with finances and objective measures of income and the ability to provide for basic needs. On the other hand, however, significant reductions in social contact was found between time 1 and time 3. Social contact was determined by the frequency of contact with the non-family member. It was determined by the frequency of contact with friends, that is, anyone who's not a family member or a relative, which might be slightly decreased due to the new changes and activities that the tenants were involved in. The Community Integration Questionnaire, or CIQ, was a measure that was used to assess the degree to which an individual is integrated into his or her home and community. Participants completed the CIQ at baseline and each subsequent interview. The CIQ consists of 15 items that form 3 composite subscales. These subscales include home integration, that is, the participation in activities related to the home; social integration, that is, participation in activities related to socialization, including with family members; and finally, productivity, that is, the participation in educational or vocational activities. An overall CIQ score is obtained by summing the scores on all 3 CIQ subscales. Scores can range from 0 to 29. A higher score indicates greater integration, and a lower score reflects less integration. The CIQ is intended to measure an individual's level of integration into the home or the community. Most of the questions are directed at how the individual performs a specific activity within the household or the community. This is a graphic of some of the questions that you might see on the CIQ. For example, we ask participants who usually looks after their personal finances, such as banking or paying bills. We ask them to approximate how many times per month they participate in the following activities: shopping, leisure activities, visiting with friends or relatives. We ask when you participate in leisure activities, do you usually do this alone or with others? We ask if the participant has a best friend that they confide in. Results from the Community Integration Scale showed that there was no statistically significant difference found between time 1 and time 3 for total CIQ scores and all CIQ subscales. This indicates that overall community integration, participation in activities in the home, and participation in social activities, such as shopping, leisure activities, visiting with friends or relatives, remained relatively stable across time. Although there was no statistically significant difference found between both time points, all CIQ overall scores were higher at time 3 compared to time 1, which indicates some improvement post-program implementation. A modified version of the Health, Social, Justice Service Use, or HSJSU questionnaire was used to assess the use of health and emergency services. This tool assesses issues such as the number of emergency room visits, phone calls to crisis line, visits by crisis teams, and ambulance trips made in the preceding 6 months. Paired sample t-tests were conducted to assess whether the frequency of community, health care, emergency, and justice service use during the 1 and 6 months interval prior to the first and final interview differed among participants based on responses. There was a significant increase in the frequency of home visits from a health or social service provider in the past month, between time 1 and time 3. This could be attributed to an increase in CHO worker visits from the implementation of the program. No other significant differences were found between time 1 and time 3 interview for all use of other community, healthcare, emergency, or justice services. This indicates that service use remained stable over time, except for increase in frequency of home visits from social service providers. Qualitative analysis was applied to focus groups conducted with tenants, home staff, homeowners, staff from the Ministry of Health, and staff from community agencies. Focus group questions examined stakeholders' perspectives of the new CHO program by identifying issues, solutions, and recommendations for improvement. Baseline focus groups included tenants and homeowner perspectives, while time 3 included tenants, homeowners, home staff, staff from the Ministry of Health, and staff from community agencies. Each focus group was audio recorded, transcribed by a research assistant, and then validated by a different research assistant. The qualitative data was quoted into categories which were synthesized into broader themes. Focus groups were analyzed separately, but the emergent themes were collectively grouped for each focus group. This graphic represents the key qualitative findings. I'll go through each of the findings in more detail in subsequent slides. The baseline evaluation was conducted to identify how stakeholders, tenants, and the homeowners perceived the new CHO program and to recognize their expectations for the effectiveness of the modernization and the implementation. The objectives of this round was to identify similarities and differences in perceptions held by the CHO tenants and homeowner staff for the purposes of improving the process. Findings indicated that while there were some similarities between tenants and homeowner staff regarding the CHO program, there were also differences that needed to be addressed. Both tenants and homeowners staff believed that these changes would be beneficial in terms of increasing financial support and social inclusion, improving quality of life and community integration, and promoting independence. Tenants were generally more positive about the increased financial support and community staff support, although they did reveal anxieties and fears from the changes and concerns about the lack of information regarding the changes. Although homeowners and staff acknowledged the potential benefits for the tenants, they were generally more negative about the tenants' capabilities to comprehend and apply these changes effectively, especially in regards to the tenants' budgeting and decision-making skills. Both tenants and homeowner staff had concerns about the ways that the CHO changes were introduced to them. There were concerns related to lack of information, lack of communication, unclear guidelines, and role description. Time 3 evaluation was conducted with stakeholders, tenants, homeowners, home staff, as well as staff from community agencies and staff from the Ministry of Health, to identify issues, barriers, facilitators, challenges, and outcomes of the new CHO program. The objective of this round was to evaluate the implementation process in regards to what was effective and what needed to be improved. Similarities and common themes that were shared by all stakeholders were identified. In addition, some themes from each participant group were also identified. The purpose of this final round of analysis is to improve the process of implementation for future rollout and provide recommendations and implications for future steps. In terms of the facilitators that were identified, 5 major themes were shared by all groups. A. Effective collaboration among stakeholders. B. Active communication, that is, regular meetings with tenants for updates. C. Bringing any issue to the LIPG meeting for problem solving. D. Engaging everybody in the process. And E. Involvement of the hospital staff. The majority of stakeholders were effectively collaborating towards successful implementation. The home staff most frequently mentioned that they're getting more help from community agencies regarding accounting issues, social activities, and medical appointments. An additional facilitating factor was effective communication between the Ministry of Health and community agencies. Besides having LIPG, regular meetings for updates and problem solving was essential for effective communication and for resolving any raised concerns. Engaging all parties in the implementation process, including hospital staff, especially during the transition, helped to facilitate the process. In terms of barriers that were identified, stakeholders did identify that there were some barriers to the effective CHO implementation. A. Lack of appropriate amenities. B. Unclear responsibilities and role descriptions. C. Conflict of organization's interest, profit versus nonprofit. And D. Perceived power struggles. And finally E. Inadequate collaboration with stakeholders. Stakeholders expressed that there was a lack of basic amenities in some homes which considered essential to make life easier and more private. Unclear roles and job descriptions was one of the most mentioned factors as a barrier. Lack of role clarity led to tension and conflict between stakeholders. Homeowners, home staff, and CHO staff were unclear about the scope of their responsibilities, which includes the role purpose, reporting relationships, and the key duties expected of them. Additionally, profit versus nonprofit philosophy of homeowners versus community agencies was mentioned as one of the barriers that led to creating conflicts of interest, leading to power struggle issues. Inadequate collaboration due to unclear job description and power struggles was mentioned by some stakeholders as a barrier to effective implementation. In terms of the challenges that were identified, stakeholders addressed some challenges during implementation of the changes. A. Homeowners were fearful of losing control. B. Lack of readily available transportation. C. Financial constraints. And D. Unhealthy behavior of tenants. And E. Tenants' limited financial literacy. Due to the unclear role description and lack of information, some homeowners expressed fear of losing control over their homes. Additionally, financial constraints were identified by some stakeholders regarding home staff rates, home restructure, renovation, and appropriate living standards. A lack of readily available transportation in some homes was also mentioned as a challenge. This was due to tenants being responsible for paying for their transportation and/or there was limited transportation services provided by CHO for people who cannot use public transportation. Financial constraints were identified by stakeholders. Some homes were lacking in funding and resources. For example, no perks for homeowners, issues with the funding model, and inconsistencies in reimbursement were reported. Unhealthy behavior of tenants was recognized by stakeholders regarding two areas: unhealthy eating behavior and unhealthy spending. Tenants' limited financial literacy was identified by some stakeholders. They expressed a need for tenants to be educated on how to spend their money appropriately. There were also some group-specific views that were identified. Some specific themes for each participant group were identified. For tenants, they were satisfied with the increased support and one-on-one support by the CHO staff. However, they expressed a need for more activities, community involvement, and more education on how to budget. Homeowners identified some positive areas such as increased opportunity for mental health promotion and easy access to the Ministry of Health, which facilitated communication and collaboration. They also recognized some areas that needed improvements, such as limited availability of CHO workers and difficulties with administrative activities. Home staff identified some areas that facilitated their role in the homes, such as promoting mental health well-being of the tenants, organizational skills of the CHO staff, improved access to healthcare professionals, and organizing and structuring home activities. Community agency staff identified some positive areas, such as improved rapport and communication with tenants, and improved relationship between CHO staff and homeowners. On the other hand, they identified some areas that needed improvement, such as the lack of standard medication administration protocol and inadequate food quality and quantity. On the whole, all stakeholders believed that it was necessary that the modernization of the Homes for Special Care program took place. The evaluation that we carried out has some recommendations for the next phase of the CHO modernization. These recommendations are grouped into three different categories. The first category is standardizing organizational functioning. This includes revising the contract to include clear and detailed language to prevent individual interpretation and providing uniformity and guidance of action. The need for common organizational practices such as wellness plans, reporting system, medication protocol, food quality and quantity. Clarifying roles, responsibilities, and job descriptions. Early planning of implementation, longer transition period, creating a space for tenants' privacies, office spaces to be provided for tenants to meet with CHO workers, maintaining individualized support, engaging people with lived experiences, and discussions needed regarding the choice of the administrating agency and whether this should be different from the services providing agency. A second area was transparency and collaboration between stakeholders. This included improving collaboration, enhancing communication between the different stakeholders, promoting accountability, and addressing philosophical differences, such as the profit versus nonprofit dilemma. Mechanisms for conflict resolution between homes and agencies should also be identified. The third area was education and training for stakeholders. This included additional training of home staff and homeowners, enhancing tenants' competency as well. Our team also came up with tips for future implementation of CHO in subsequent phases of the modernization. The first tip is to establish a regional advisory group for each region, including representation from the ministry, homeowners, community agency, tenants, and the evaluation group. The advisory group will have a clear term of reference. This group can deal with emergent issues and provide a community of practice. Another tip is to support a community of practice that includes community agencies, homeowners, and home staff to share information and develop a shared repertoire of resources, experiences, tools, and way of addressing recurring problems. We also recommend that gathering documentation, forms, role responsibilities, job descriptions, and guidelines that were developed by the ministry, community agencies, and homeowners, such as wellness plans, reporting systems, and medication protocol. The current LIPG members are also encouraged to bring these examples to their meetings to create a practice manual for further implementation. Other tips include the recommendation of maintaining a toolkit that includes examples of documentation forms, role responsibilities, and job descriptions developed by the ministry, CHO agencies, and homeowners. Having posters and meetings in individual homes letting people know about the changes and general information about the CHO program. Also encouraging community agencies to hire administration and CHO staff positions prior to the implementation. In conclusion, the CHO program evaluation revealed the tenants' quality of life, community integration, autonomy, and financial adequacy have remarkably improved. There's also been significant improvements in the satisfaction with their living situation, the satisfaction of their daily activities, and satisfaction with financial situation of the tenants. Focus group supports the need for continued learning opportunities to enhance tenants' budgeting and other life skills. Tenants are also able to improve autonomy and independence with the appropriate support through the CHO program.